Ladies and gentlemen, welcome to the clinical navigation of advanced BRCA1 mutated ovarian carcinosarcoma in elderly patient. Diagnostic challenges, treatment complexity, and a role PARP inhibitor. My name is Nam from Vietnam. There is no conflict or disclosure to declare. Now, I would like to begin. The 74-year-old female with history of well-controlled diabetes, hypertension, presents with a chronic abdominal pain. 2 months prior, she developed a constipation and unintentional weight loss, 7 kg over 2 months. 1 month prior, she had a persistent lower abdominal pain from the right iliac fossa radiate to the left side, worse in the morning and before defecation. 7 days prior, the pain worsened, prompting hospital presentation. On admission, she had abdominal pain, VAS 6 out of 10, inability to pass stool, fatigue and poor appetite without GI bleeding and vomiting. Family history highlight the esophagus cancer, breast cancer, and hematologic malignancy. On physical examination, she was fatigued, otherwise normal, diffuse abdominal tenderness with multiple palpable masses, abdominal fullness, and aside was critically foul, atrophic uterus with tenderness and adnexal masses. Given her age, weight loss, and progressive bowel symptoms, colorectal cancer was suitable in the NICE guideline, but ovarian cancer was clinically considered. Here, we will do the test for both diagnoses. However, the FIT is unavailable in Vietnam, so we will do the remaining tests. Imaging revealed the right ovarian mass, about 6 cm, with aside and peritoneal involvement, along with a segmental pulmonary embolisms. CA125 around 1,400, HE4 more than 5,000, supporting ovarian malignancy. However, the CEA and the CA72-4 was elevated, raising the concern for gastrointestinal involvement or metastasis disease. Final pathology revealed the ovarian carcinosarcoma, figure stage 4, molecular profiling showed PD-L1 30%, low tumor mutational burden, predicting the limited benefit from immune checkpoint inhibitor. So now, should we go with the palliative care or do more tests? Surprisingly, the positive BRCA1 mutation definitely become turning point in management. Based on this, the team designed neoadjuvant platinum-based chemotherapy. There are some positive outcomes and anticipate complication. In neoadjuvant phase, there are some objective and functional response at the first chemo cycle, which is resolution of pulmonary embolisms. After the second cycle, the treatment was complicated by 2 episodes of recurrent C. diff infections over 20 days, treated with vancomycin and ciprofloxacin. 7 days later, she developed a malignant large bowel obstruction due to the peritoneal metastasis invading the sigmoid colon, requiring urgent diverting colostomy. After the 3rd cycle, the marked improvement in symptoms and tumor marker is shown. She then underwent the interval debulking surgery with optimal cytoreductions. Post-operatively, she developed the surgical site infections with the extensive drug-resistant Enterococcus faecium, successfully treated with the linezolid, the only sensitive antibiotic. During adjuvant chemotherapy, she experienced a recurrent asymptomatic leukopenia, resulting in multiple treatment delays. Given the platinum sensitivity and BRCA1 mutation, she transitioned to the olaparib maintenance therapy in April 2025. After 8 months on olaparib, imaging showed the complete radiologic response with no residual disease and the CA125 suppressed to 6. In conclusion, 8 key points including advanced cancer frequently mimic each other, so never single-track the cancer. Guidelines don't make the diagnosis, clinic do. Compared with the surgery alone, neoadjuvant therapy reduces systemic risk up to 40% without surgical outcome. Don't just react, but anticipate the complication. In high AMR setting, infections can be the dominant threat on oncology care, especially in Asia-Pacific region, with high recurrence and severity of C. diff and Enterobacteriaceae species. Modern oncology is vulnerability driven, not histology alone driven. BRCA tests, first introduced in early 2000, remain limited in many LMIC. In Vietnam, routine use began only in 2022, driven by the target therapy availability. Last, PARP inhibition maintenance in the SOLO-1 trial tells 70% reduction in risk of disease progression or death, fundamentally altering survival expectation beyond 5 years. This is the end of my presentation. Thank you for listening.